This is safe surgery in a very difficult case, Phaco in IFIS or Intraoperative Floppy Iris Syndrome, and this condition is usually seen in elderly males who have been taking alpha blockers for the treatment of their prostate situation. And there are some telltale signs in these cases where preoperative mydriasis is poor and the iris itself appears boggy, as we can see it here. This is the fundus, which is unremarkable except for the media haze caused by the cataract. It's a good practice to use intracameral lignocaine with adrenaline in these cases, as it dampens the effect of intraoperative floppy iris syndrome, and then filling the anterior chamber with viscoelastic, and mind it that the anterior chamber has to be tightly filled. That will also aid in dilating the pupil, which is usually poorly dilated in these cases. Initiating a capsular rhexis flap and propagating it using a rhexis forceps, and at this moment we can appreciate that the pupil is not very large. It is hardly 3 to 4 millimeters in size, and that is a sign which tells this case is not going to be very easy. Now, there are options for these situations like using some pupillary expansion devices, but they will traumatize the iris even further. Now, doing hydrodissection, and here we can see the fluttering of the iris, which is very well obvious here. Hydrodissection is followed by the primary procedure, that is phacoemulsification of the nucleus. And now going inside with a phaco tip, infusion turned on, removing the overlying cortex, and then proceeding for disassembly of the nucleus using a horizontal direct chop technique using a blunt chopper. Now it's very important that fluid flow should be restricted to minimum. So in these scenarios, you usually aspirate only when it is necessary, that is when you are emulsifying the pieces or when you are washing away the contents. Otherwise, one should refrain from exchange of fluid as much as possible. So there's just like one has to use judicially the ultrasound power, similarly in this situation one has to also curtail on the amount of fluid exchange. The iris has started prolapsing to the side port, but that is not going to be a problem for us because some amount of iris prolapse can actually allow the view of the underlying contents behind the iris. So proceeding for removal of further pieces, and the one thing which I was taking care during whole of the procedure was that whenever I was not aspirating or emulsifying, I turned off the aspiration, and that prevented the iris fluttering and further reduction in the size of the pupil. Now this completes the emulsification of the nucleus. And now we are left with the cortex. Now in this situation, one has to turn off the infusion first and then only you can deposit the iris. Proceeding for removal of the cortical matter. Usually because the iris is draping over the capsular rhexis border, it's difficult to reach to the cortex and catch hold of the anterior end of the fiber. So one has to use some kind of device which can actually retract the iris back, and here we are using a T-shaped dialer which is allowing us to retract the iris in a desired way so as to expose the underlying cortex and safely remove it under direct visualization, sparing the catching of the capsular rhexis border. One has to have some amount of patience, and then it is possible to safely remove the cortex. This portion of the video is fast forwarded 1.5 times, but it is showing us all the possible maneuvers and the tricks which were done to remove the cortex here. One has to have very good foot control because keeping the aspiration flow linear is important, because when you are close to the capsule, one has to reduce the amount of fluid exchange. Again, when you have to deposit the prolapsed iris, you have to turn off the infusion and then you can push the iris back into its position. Now the cortical matter and the nuclear material has been removed, and this is the time for implantation of intraocular lens. And we can appreciate the pupil, which is hardly 3 millimeters in size, and we are proceeding to implant a monofocal hydrophobic intraocular lens. An IOL which gets trapped in the pupil like this is a sign for me that this pupil is not at all comfortable or cooperative pupil. But though the surgery has been finished, so that is of no consequence for us now. The IOL has been implanted in the bag, proceeding for removal of the viscoelastic. Because these surgeries will take some little amount of time which is greater than routine surgery, and that is why there may be some amount of keratitis next day. But if cornea has not been disturbed, usually these patients they could do good. We can appreciate the amount of flutter the fluid flow is creating here, and one has to actually reach into the posterior chamber and anterior chamber separately to remove the retained viscoelastic. Hydrating the wound and inflating the anterior chamber, and this finishes of the surgery. And this is the next day post-op picture, a crystal clear cornea with some amount of haze at the site of incision. The pupil is still not very dilated, though the patient is on mydriatic. This is the day 7 picture. The patient's vision BCVA was 6.9. Thank you.